So our fourth and final section of this seminar class is the interdisciplinary professional networking and collaboration. This, I feel like, is a necessary piece to include in the informational class because we do not work in a bubble. Of course, I come from the speech-language pathology perspective, but it's important to have that interdisciplinary network, to know the professionals in your community, to know the resources, to know what they do and don't do, so that you can refer accordingly and so that you can collaborate and provide the best services for your clients. So here is a slide that I like to include in my live classes because I think it's important to think about that referral process. And it's really counterintuitive, at least for me it is, to diagnose something and then not treat it. So I asked that question, when might you diagnose tongue thrust but yet not treat it? And there are times, and we've kind of talked about it a little bit in this lecture, but there are probably three main times that I will hold off on treatment despite having an obvious diagnosis. The first of those is the obvious we talked about earlier, they're too young. So if the maturity level is not there, or if there are other things going on that you need to wait, then that would be appropriate. Additionally, if you may have a situation where there are the contributing factors that need to be addressed, then you may wait. Sometimes you might go ahead and treat at the same time. We'll talk about that in a minute. But there are times when you would just hold off on therapy. Probably the two most common reasons that I hold off. Number one is because they're flat out too busy. So again, remember, this population tends to be teenagers. They're busy. They're involved in a lot of extracurricular activities and sports. And so, for example, if I have a patient that is a track athlete and it's track season, I'm probably going to wait until they're done with their season, because the reality is they're just not going to have the time to commit. On the flip side of that, summer is a time when a lot of parents think, oh, well, we have less going on. It'd be great to do it in the summer. But summer often has its own challenges, because what helps break a habit? Routine. And what do we tend to have less of in the summer? Routine. Big long vacations or lack of routine can make it really tough to start an intensive program that requires new learning of and exercise, daily follow-up and commitment. And so just considering the family, considering the patient and the situation will often dictate whether or not I initiate therapy or not. And then the final reason is reality, and that is finances. Sometimes families will need to hold off because they need to figure out how to pay for it. And honestly, the tongue thrust therapy, that with the STTP program, it's very cost effective. It's much less expensive than orthodontia, and it actually helps that orthodontia along and helps it stick. So it is very, very valuable, very, very cost effective, and families realize that and will make it a priority. But it does take some figuring out resources to determine whether or not the treatment plan is going to be a fit for the family. So those are some things to consider about when you may not treat or when you may just delay treatment. With that said, it's generally easier to break a habit when they're younger. Obviously, the more you've done something, the harder it is to change it. So it is a fine line of figuring out what is optimal when they're old enough to commit and understand and be a player in their own remediation, but yet as young as possible, so that you can nip those habits and change that muscle posture as early as possible. So then when might you refer out? Obviously, we don't do everything. So if it's outside of your scope, then sending them to someone who is more appropriate only makes sense. Who might that be? Some of the different recommendations that may happen from your evaluation would be that you're going to recommend tongue thrust therapy. You go ahead and start. I actually start the therapy the day that I do the evaluation. So my evaluation includes the actual eval, also the education to the patient and the family. I usually like it if I can have family there, parents there if it's a minor. Obviously if it's an adult then they don't need to, but the education piece, and then I will go ahead and start them with their exercises. I have 2 or 3 that I usually will start them with depending on how they do that very first day. An ENT referral, ear, nose, and throat doctor, otorhinolaryngologist is their medical term, but most people call them an ENT or an ear, nose, and throat specialist. They are so valuable to the team. Oftentimes, like I said, not always, but oftentimes these folks have contributing factors with their tonsils, adenoids, sinuses, something that is impairing their airflow, and or even allergies. If you've got airflow restriction, then your chances of successfully changing your resting posture and breathing through your nose effectively so that you can retrain your tongue posture is going to be more challenging. It's not impossible. It does happen. I do have people who eliminate tongue thrust despite less than optimal oropharyngeal sinus areas, also less than optimal orthodontia circumstances, teeth, the structures, whatever, and even oral habits. It can be done, but it takes longer. It's going to cost more money because it takes longer. So again, if you can bring in other players who can remediate contributing factors, it will just accelerate your progress. Orthodontic referral is uncommon. Usually they're coming from the orthodontist, so most of the time my patients actually have an orthodontist already in place. But occasionally, like what I'm seeing right now, she's 9, and so the dentist has talked about a referral to orthodontia, but it's just pretty early. Really, you don't look into in my opinion, orthodontia is most appropriate when they have those adult teeth in. So if they're still getting their 12-year molars and they're still losing baby teeth, then orthodontia is usually a ways down the road. So it just depends on your client, but knowing the orthodontists who work well with tongue thrust and understand the value of remediation and elimination of that tongue thrust in the orthodontic process is really, really useful. And including them in your reports and your, especially if they are in orthodontic treatment, communication with that orthodontist is really, really helpful so that you know where they're at in their plan of treatment and they know how your tongue thrust remediation is coming along and how it's going to affect or not affect the orthodontia. But absolutely, I will do therapy with a full mouth. Usually they do. Oftentimes they have palate spreaders. Sometimes they'll have permanent retainers because they've already had the braces and the teeth are moving because of the tongue. So they're on their second or threat of third set of braces if they don't get the tongue thrust eliminated. So I often, with tongue thrust, you're working with the tongue and the muscles. You're not working with the structures. So I don't have a problem working around whatever structures are in there and are changing, because really we want to isolate the tongue anyway. Articulation therapy is most common before tongue thrust therapy. A lot of times they'll be in articulation therapy and then they'll pause and come for tongue thrust therapy, and then they may need to go back and have some additional artic therapy to knock off whatever edges are still there with that residual R, or as a lot of times the tongue thrust therapy will eliminate whatever is hanging on, but it just depends on the situation. And then finally we talked about eliminating oral habits. This is a personal one. For me, I refer out for oral habits. I don't feel like it's the most cost-effective use of my skill to eliminate oral habits, so I will send the parents with resources. I'm a fan of Pam Marshalla's book, How to Stop Thumb Sucking. I am not at all averse to giving suggestions and recommendations to parents, but having them pay to see me to follow elimination of a behavior like thumb sucking or chewing on blankets or pencils or whatever is not the most cost effective. So that's up to you. It certainly is within our scope of practice because it is oral, but it's really up to you and the resources and what's available in your community, what you feel comfortable with. So once we've made those recommendations, then we get started with the plan of treatment. I'm not going to address the plan of treatment in this particular class because this is an entry-level introduction general population course. I am going to have the next course through the STTP Training Center is the Perspectives in Tongue Thrust. This particular course will dive deeper into the clinical dilemmas and solutions that we kind of touched on. It is going to have more clinical information. It will be more appropriate for clinicians, specifically in speech-language pathology, dental professionals. I have had dental assistants, dental hygienists, actual dentists who have participated in this course in the past and found it to be valuable. Also, the oromaxillofacial specialists would be appropriate for this particular, what I'm calling the intermediate course. So it is not the certification course for those of you who are wanting to get certified with the STTP. That is coming. That will be the advanced course. And it will be much more extensive. It will have the actual program and actual clinical application and testing with that. So for both the assessment and the treatment. The next course, the Perspectives, will be that intermediary. We will talk about the protocol. We will talk about actual assessment and treatment intervention, but it will not be specific to the STTP. Okay, so that course is coming up. If you're interested in it, please do go back to the training center and register for that course. And along those same lines, thank you very much for your participation in this course. Here are the references that I've referred to. As you know, I broke this long lecture into 4 sections to make it more user-friendly for the rear end and the attention span. But these references go through the entire course. I also would like to take a minute at this point to ask you to please take the quiz, to go ahead and see if the knowledge that you took away from this was the knowledge that was hopefully intended, that it came across properly, and also feedback and reviews of the course. Anywhere that you can help give feedback and information to spread the word about tongue thrust, about the STTP Training Center, about the Debunking the Myths intro course. My goal is really to make this a resource for folks who have been told they have tongue thrust or who have heard about it but don't know where to go and are getting that conflicting information. So if you could give some feedback on that, on the online delivery method and how effective that is working for you, I would greatly appreciate it. And of course, you know, the more we talk about it, the more we review it, the better the exposure and the more people we can touch. So thanks so much for joining me. I appreciate your time, and I hope that you took away some valuable information from this.